Hello everyone, my name is Jen, I'm Head of Programming here at Science Gallery London, and I'm really delighted to welcome you to Science Gallery, which is part of King's College London and a place to grow new ideas about arts, science and health. Our public programme explores future-facing questions located around the intersection of art, science and technology through conversations, exhibitions and events like this. So before the event starts, I'm just here to do housekeeping. So fire exits are just behind me up the staircase here. We're not expecting a practice fire alarm, so if it does go off, please leave the theatre. The toilets are located through the double doors at the back of the theatre, and we appreciate it's really hot tonight, so if you need to move around, leave the room for a little bit. There's water in the atrium, the ground floor is cooler as well. We are recording the event tonight, and we will be sharing the recording with you after the event. So tonight's event, the big question, who will fix maternity care, is part of a wider programme here at Science Gallery London that coincides with the 300th anniversary of Guy's Hospital. So within our public programme over these past few months and up until the end of July, we'll be exploring healthcare, equality and social justice through events and discussions like this. So it's my great pleasure to introduce the chair of tonight's event, Dr. Claire Feeley. Claire is a senior lecturer of midwifery here at King's College London, specialising in physiological birth, human rights frameworks in maternity care, and the sociocultural and political context shaping midwifery practice. Central to all of Claire's work across education, research, and practice is the improvement of maternity service delivery to meet the needs of all those within her care. So thank you, Claire. Over to you to introduce our panelists and tell us more about the event tonight. Thank you.
Also, thank you for the introduction and the invitation to chair this really important event with such an amazing lineup of panelists. So whether you are part of maternity services in this audience or not, most of you are very much aware of the ongoing and acute crises, or perma-crises we could call it, in maternity services. Weekly, oftentimes daily, we are getting news articles, press releases, umpteen social media posts sharing extraordinary issues. Unsafe staffing, traumatised women and birthing people, inequitable access to care, inequitable experiences of care, particularly for those in marginalised populations, and profoundly shocking differences between mortality rates depending on the colour of your skin, where you live, and whether you have financial resources. However, for those of you who've been in maternity for a while, and I've just counted, I've been in maternity for 20 years now, right from my beginning voluntary days, you will know that these issues sadly are not new. In fact, midwives, other healthcare professionals, campaigners have been raising the alarm for ever such a long time. So there's been campaigning, there's been protesting, there's been striking. The first ever midwife strike, clinical midwife strike, I think was 2014. I say I think because I can't remember that far back, but I was there, I was out on the picket line. And those long-standing campaigns have absolutely centred both improving the care for the families that we're serving, but also to improve the conditions for the working conditions for staff. For as many social media commentators are sharing with us, as a health professional, my working conditions are your birthing conditions, and vice versa. Much, but by no means all of these issues, and I want to be clear, is not all bound by these issues that I will share in a minute, but a lot of it reflects the complex landscape that the UK faces. We've had 14 years plus of austerity, Brexit, the rise of the hostile state to migrants, the pandemic, geopolitics, global geopolitics, and the recent significant rise of the far right, emboldened by big tech and the growing fear of everyday people that their lives are only going to continue to get worse. I mention these issues because maternity care and their services are not immune. Far from it. We could argue that maternity services are the canary in the coal mine. Because when maternity services are stripped back to its bones, when fascism rises, we know that from substantial evidence that this negatively affects our whole populations. The health and well-being, widening in health inequalities and worsening outcomes for minoritized people. And of course, staff also work in those stretched and politically toxic conditions. They also face immense challenges. That being said, also being mindful that staff can be perpetuators of harm. In many circumstances, such harm is unintentional due to all those structural issues that I've just mentioned. And that gives rise to moral distress, injury, burnout, and leaving the profession when we so sorely need those staff. On the other hand, we have to hold the simultaneous truth that some staff do perpetuate harm due to their own belief systems, that not everyone has equal standing in the world, or where they supervalue paternalistic caregiving. So as we, the royal we, the service, the staff in the service, we need to hold ourselves accountable while we continue to struggle to improve maternity services structurally, and that's absolutely vital and essential. We must insist that the negative belief systems that do permeate parts of maternity services are challenged, and those poor cultures must be transformed. So in that context, today's event is incredibly timely. Tomorrow we'll see the release of the Nottingham investigation by Donna Rockenden, one of the many inquiries into maternity service failings. And the early press releases have highlighted systemic racism and poor attitudes towards women, while also recognising that whistleblowers were not listened to. So this really does reflect failings of senior management. And then next week we have the national investigation published by Baroness Amos, who appears to have taken a whole system approach, so we will await those findings with bated breath. But equally, and interestingly, worryingly, maybe good news, we've had another Prime Minister resign. I don't know what we all make of that, and I'm not here to tell you what to make of it. But the point being is our macro politics is in constant turbulence. So as the turbulence continues, and we're all here because we want to solve the maternity service crisis, I fervently, and I'm sure you all share my sentiment, that we fervently hope that solving this crisis is not just can kick down the road yet once again, fingers and toes crossed. So the scope of this question, to explore the big question, and I actually think the humongous question here, who will fix maternity care? And with such a huge question and so much pressure on our panellists to answer this ginormous question, I am so delighted to introduce. We've got Dr. Gemma McKenzie, researcher in human rights in childbirth, freebirthing and obstetric violence, who founded the project leading to Threads of Protest, which is here on display. Please go and see it. Gemma combines creative practice and research to amplify the voices of birthing people. We have Dr. Karen Jarosz, consultant obstetrician and gynecologist at Imperial. She is also a director of Imperial's Clinical Academic Training Office and chair of the research group at Tommy's. Take a breath, that's amazing. Contributing to research that improves maternal and fetal outcomes and addresses inequalities in pregnancy. Last but not least, Dr. Annabelle Sawemimo, NHS Sexual and Reproductive Health Registrar, academic, founder of the Reproductive Justice Initiative, addressing racial inequalities and reproductive justice in healthcare. She is also a trustee of Birth Rights and an ambassador for Birth Companions. And I'll give a quick plug. She has got some of her books with her divided. So I'll embarrass her a bit more at the end, and so you can go nab her. So I just want to give you all a massive welcome, and thank you all for being here this very hot evening. So I'll start with our first question for the panel, and each of you will have about 5 minutes, roughly, to answer. And apparently I've got a clock somewhere. There it is. Wonderful, because I'm meant to be timekeeper as well. So you have about 5 minutes to answer. Given our audience tonight may not be quite so familiar with all the complex issues in maternity care, can you share from your perspectives, your own disciplines or your research, what is wrong with maternity care in the UK now, and what impact is this having? And if I go to Annabelle first.
Oh, always have to come to me. This always happens to me first. Thank you so much for the introduction, and also really appreciative of people coming out today, given the heat, and hope you all have pleasant journeys back, because I know lots of things aren't working. So for context, also, I am actually a consultant now and have been for a couple of years, and I'm based in Lewisham in South London, which comes with a whole kind of different perspective, I think, when you're also trying to be in more of a leadership role rather than kind of training and learning from others. So it is a massive question. So you've painted quite a good scene, I think, of the landscape of what's happening in terms of politically at the moment. I think certain things that I'll add is that more widely within the maternity system, we've seen lots of people campaign, from celebrities to the everyday person, and a lot of us on this panel also have not good experiences with the maternity system. So lots of different people are not having a good experience when it comes to maternity care, that have quite different lived experiences across class, across socioeconomic background, racially, our sexuality, gender. We know that it's impacting a lot of different people. However, within this, and what you alluded to, we also know that some people are experiencing the system worse than others, and I think that's because the same problems are being amplified. So we've had reports from, you mentioned, I'm trustee from Birthrights. They did much more of a qualitative report, their Broken Bodies report, not Broken Bodies, looking at racial inequalities, and we see this echoed in very many reports, essentially. We know that there's been that gap from Embrace around maternal mortality for Black and Asian women, which has been 5 times more, and it's fluctuated, and latest it's 2.5 times more, kind of. But even that statistic is really the tip of the iceberg, and I'm sure other people will speak to this, because we're also looking at morbidity. So for every person that doesn't have a good experience, and a lot of those people that don't have good experiences will have other comorbidities, whether that's mental health, whether that's other underlying medical causes that are causing poor outcomes. But then there's lots of people within that that don't necessarily have a maternal death, but are having a very negative experience. And I think we're only kind of getting the tip of the iceberg of those people, because where do people take those things? People on this panel have taken it into advocacy work and channeled it into their job roles. But in my clinical practice as a sexual reproductive health consultant, so should have started with this, but we're a small specialty. So we used to be a subspecialty of obstetrics and gynecology, but essentially now what we do is more community gynae combined with sexual health. And there's not that many of us, and we mostly live in integrated sexual health clinics. So we see people, and we do a lot of things around contraception, but we do other things. People do outpatient hysteroscopies, people manage miscarriage. Job plans look different elsewhere. But what we do is we speak to a lot of people throughout these various stages, life course. So I see people that are adolescents that have just started, their menstrual cycles, just maybe started sexual activity, right through to having a menopause clinic and dealing with people at that, managing people at that life stage. And what I'll say is that when people do, first of all, there's a few issues feeding into this wider picture. We don't really talk about pregnancy and childbirth until people are pregnant. There's really poor education. Half of pregnancies are unplanned, but even within that 50% that are planned, that looks very different to different people. People get a massive shock about what it seems, what it appears to be, what it becomes, how they navigate it. So we've got that whole issue. We also have the issue that when people do become pregnant and they experience trauma, it's not dealt with well. Because we've got this tip of the iceberg, there are a lot of people that don't necessarily meet the criteria or seek out perinatal mental health support, but they are traumatized. And that is something I see a lot of in my practice, because I do and see a lot of psychosexual health. So that can appear like relationship breakdown, people having low libido chronically through the rest of their life. Obviously, some things that are much more profound, like vaginismus, which some of you might be familiar with. The pelvic floor kind of goes into spasm, very difficult to have sex, vaginal examinations, things like that. Can be, because of childbirth, can be borne out for other reasons. But I would say in my practice, I make it quite commonplace to ask about delivery experiences, You should throughout your gynae obstetric history anyway, but I ask about it within the context of my menopause clinics, other things, because I find these issues rear their heads again at this time, because it's another reproductive change, like it is for puberty. When people start experiencing low libido or other issues, it brings back all these memories, and lots of these things have not been addressed. So all of this is to say that when we think about the maternity landscape and some of the issues that you've touched upon, I actually think we're doing ourselves a huge disservice, because I think it's often looked upon as an issue in isolation without people looking at it throughout the whole reproductive life course and how we're planning for it. And I think we have to address it within that whole thing. I think things are amplified during maternity because medical misogyny means people have, they're made vulnerable by a toxic system, right? So it gets amplified. But I don't think you can address maternity without really scrutinizing the whole framework of reproductive health and that life course approach. And I'll leave that there for now.
Amazing. Karen, I'll come to you.
It's coming on to me. So,
I'm going to mix and match this, by the way. So,
so
I'm
you
going
want
to keep you on your toes.
so just remind us, you want us to...
Yes, let me tell you the question. For those who might not be so familiar with all the complex issues in maternity care, from your perspective, professional research, whichever hat you want to wear, what is wrong with maternity care in the UK?
I'm going to get a Nobel Prize.
What impact is it having?
No, so I will start with thinking about why I went into the NHS. So I grew up in West London. I was born at West Middlesex Hospital, for those of you who may know it. And it was a very exciting sort of early years for me. I saw my mother dressed in those wonderful hats that nurses used to wear. You know, the belts round, and everybody looked wonderful. It was pristine. And it was like, for me, a dream to come and work in the NHS. It was a clean environment. It was a place of care. It was the healthcare of the future. And what do we have now, the NHS, many years later? I wouldn't say I'm 25, but I've now worked in maternity for 25 years. And where are we now? You know, what is actually the NHS when we say the NHS? Is it a structure? Is it a building? Is it separate people plotted around London who are delivering care on different timelines, guidelines, and support? Actually, the NHS is the people. So when we look at how we deliver care, we have to think inherently, what have we done to the people? Who are the people that are delivering care? When I look at my wonderful midwifery colleagues, some who are sitting at the front, I think I should get an honorary RCM membership, by the way. I'm still waiting for that. Somebody nominate me. Who I think are absolutely brilliant. Do we nurture them? Do we grow them? Do we hold them in what they face so that they're able to truly give the care? Or are we just giving them checklists to tick off, documentation to continue to write, such that they're not able to truly deliver the care that they want to give? Do we then hold the midwives and accelerate them into wonderful roles that they should be in? They should be in roles that at consultant midwifery level, roles where they're specialists in diabetes care, specialists in perineal care, or do we still keep them in the band 6, running around the labour wards, not delivering the care that they want to give? Do we put them into preventative roles? I love Call the Midwife, it's one of my favourite programmes. And do you remember that community centre where they would all come and all the pregnant women would be knitting together? Do we allow the midwife to really connect with the women in the way that they should do? And what happens to the education? I don't know if many of you know why the NCT started many years ago. The NCT started because doctors invented syntocinon, and of course they were terrible when it came along. So they were inducing loads of women. So the NCT rose up to say, actually, we don't need lots of induction. We still want normal birth. But unfortunately, now that narrative around education has been taken by the NCT, been taken by the social media. Why is it not our midwives that are delivering that really true care, who really understand and hold and know about the complexities of our maternity system and prepare women fully for what they're going to face? And then we look at our doctors. What are our doctors doing? We're running around almost trying to be within a system to deliver the care when we're not always at the front face. where they're writing reports, risk reports, trying to make sure that we're not going to get CQC'd, or making sure that we don't get Donna Ockerton or not in a report. And what I then call to mind to myself is I led on the perinatal mental health conference at the RCOG. And the saddest session was a session which was breakout, and we would talk about maternity culture, because that's one of the great passions of mine, is seeing the midwives actually crying who had been involved in the scandals. I work at a scandal unit. Where have we become a whole nation of people that condemn and put down our workforce such that they can no longer deliver the care that they choose to deliver? So it then brings me on to culture. So what do I see when I go around? I'm also still the head of school for training in London, oversee 26 hospitals, and it's fascinating. I get to go around to different units and look at the quality of care that they give in that unit for training. But of course it aligns with care, and invariably people will walk into the room and you can see the energy in the room from that team, whether it's a team that's cohesive, that works together on a psychological basis. They've got that cognitive flexibility. They're not just echo chambers. They're people that are willing to want to make change, that work together. And we know, when we say about the NHS, we know that actually it's going over and above what we're paid. That usually makes the difference. I don't think people are given enough time to develop their team culture. When you look at any other institution, whether it be banking, education, it's core team building exercises, time to sit back and think about how they can improve a system rather than continue just to walk and work within the system. So for me, I will say my strong sense of when I look at maternity is that we need to sort out the culture. We need to really appreciate the people that we have, and we really need to allow them to flourish and grow professionally and psychologically.
Thank you. Last but not least on this occasion, Gemma.
Yeah, so I've got quite a different background to Karen and Annabelle. So how I got into this work is I originally trained as a lawyer, and I worked in various environments, like with the police, with third sector organisations, always to do with rights. And then when I got pregnant nearly 17 years ago, I went to the maternity system, knew nothing about midwifery, knew nothing about what to expect, and I had a really violent and abusive and degrading experience that traumatized me, that left me with severe mental health problems, physical problems. I felt like I'd been hit by a train, and it took me years to feel normal again. I've had 2 other children since, and even though the experiences were not the same, in some ways they were equally as bad. So I got involved with AIMS, I presume people know, Association for Improvements in the Maternity Services, and at first I contacted them for support, and then I started to get involved as a volunteer. Then I decided to leave my job with the police and go into academia to try and understand a bit more about what happened to me. How did I consider myself a reasonably intelligent woman, how did I just get completely steamrolled? So my PhD was in freebirth, so women's experiences of freebirth, and because I wanted to understand, how did they say no? How did they disengage? How did they get to do what they wanted to do but I couldn't? And the things that people told me, I expected a kind of mental health response, but it was not a mental health response. People were really talking about obstetric violence. And that linked into my own background. So my interest is in rights, women's rights, human rights, consent. How do we know if somebody's actually consented? What is obstetric violence? How is this manifesting? What is the impact on women? And I think for me, certainly, rights are often left out of the conversation when we talk, when we have all these maternity reviews. There's a lot of discussion of the medicalisation and things like that, and there's a lot of discussion of birth trauma, but you very rarely see the words obstetric violence. And obstetric violence itself it can be interpersonal, it can be institutional, and it can also be structural. So it kind of comes back to what Annabelle and Karen were saying about culture and the need to completely overhaul what we've been given by this maternity system that we've got. So that's my direction, that's the interest that I've got. And I think I see a lot of that, not only in the research, but just to tag on to the textile work. One of the final points I wanted to make that is often forgotten, when I go and do crochet workshops, it attracts a certain demographic, which is usually older women. And
I've just done one.
oh, really? You're only 21. So I go to these crochet workshops and I hold them when we were trying to make the exhibition and get people to make crocheted granny squares. And women that were given birth in the 70s, the 80s, even the 90s, some of the stories that they had, as soon as they look down and they're doing the craft, because they're not looking into people's eyes, they kind of come out with stuff. Some of the stuff is absolutely shocking. One of the women that I spoke to, she was sobbing during the crochet workshop, and her son was 42. So I just want to make the point that we talk about contemporary issues, but there are women walking around in our society with severe baggage from things that have happened decades ago. And these are the population that are often forgotten when we talk about problems in maternity. It's almost like historical abuse. So that's my focus: obstetric violence, human rights, and that's the direction that I'm mostly concerned about.
And before I move on to the next question, so it doesn't just feel like a old-fashioned survey, it's firing questions. Any of you have anything to add to each other's points? Anything that's come to mind? Any reflections on each other's?
I mean, the only thing I will add is that when I look at the whole of the medical system, it's very much a patriarchal system, and it pervades really strongly into maternity, where it's there, you'll do what I say, you're a mother, you don't know best, you're pregnant. And that, in terms of what you describe, I see that in other people in the way that they are counselled or held in situations, because when it's one-on-one, there's quite a serious power dynamic, which I'm not sure if people always fully understand, particularly from the obstetric perspective. And it's really important when you're actually engaging somebody is actually to flatten that power dynamic. So then it allows a degree of psychological safety. If you don't flatten it, it almost removes the capacity of the woman within labour, because they don't have the voice to speak, because nobody's listening to what they say. But I think that's often under-addressed, and I think it pervades all the way through the gender health gap. Yeah. So we see it in menopause, we see it in heart cardiovascular outcomes, when people are trying to advocate for themselves. So I think that's really important to look at the power, and how do we take the power and put it back into the women when they're using our maternity systems.
And just to add to Karen's point, I think the other thing that we have to broaden this out as well. It is about, I suppose, patriarchy, which is about power. But, there are wider discussions to be had about medicine as an institution as a whole. And in my work, I'm not a medical historian. I've got a medical anthropology background, and that's kind of the methodology that I'm using for my PhD, which I also forgot to mention is on, I'm studying at King's, and it's on the experience of Black women with long-acting reversible contraceptive methods. So I talk about reproductive coercion quite a lot, and that's quite central to a lot of my work. Now, so when we think about medicine as an institution and we look at how we've kind of galvanized expertise, there's quite a torrid history of how midwifery has been expunged in different areas. It's unique to different places, so I think it's really important that we don't generalise. But if you look at kind of how it's expunged out of the colonial Caribbean, there was people that were quite competent delivering babies safely, and that was kind of got rid of systemically for quite clear reasons. It was seen as a threat to power, it was seen a threat to kind of plantation physicians who were called and made money and so forth. And the reason I talk about these things is because most historians concur that history goes in cycles, and the reason we learn history is because there's a lot to understand about our contemporary present, but also how things repeat themselves. And the reason that we have certain systems in place are not necessarily because they're better. You know, there is an element of safety, but I think when we look at reproduction as a whole, there are other areas to learn from. So I speak about reproductive rights, the full spectrum, I speak about abortion care, and there's a lot to be learned about. Safety is often used as a stick to also beat people with and actually stop sometimes systems that could be better experience-wise, safety-wise, because medicine likes to galvanise kind of and concentrate power. And there's numerous examples of people not going for the option that is better for the patient and, you know, protects their autonomy because of money and greed. And I'm not saying that's always the reason, but I think we can't really disentangle this conversation and speak to some of the themes, I'm sure, in your PhD thesis around free birth without talking about that historical institution that is medicine as we know it today and how it's been set up to be and still is very much reinforced along these lines.
And then that co-creation that's come with the institutionalisation of medicine, because those two weren't mutually exclusive back in the, I did a deep dive for my PhD, the rise of the hospital. I urge any of you to go down those rabbit holes, because it really does bring to light that combination together as to where we are seeing this in our maternity services. Who knows what would have happened if we didn't have those hospitals and and it's called the rise of the hospitals, and that wasn't necessarily for altruistic reasons either. But thank you for that. Thank you for adding to that. And yet it's really important to keep we're succumbing to, with all the failings in UK English maternity services particularly, we're succumbing to English exceptionalism once again, that for some reason we don't want to learn from other countries who are doing far better than we are. You know, we can look at the Nordic countries, and I know it's not perfect. I can see Elizabeth looking at me. The Nordic countries are not perfect by any means, but if we want to look at a baseline of mortality combined with caesarean sections rate, for example, women or their babies, they're definitely doing a lot better than we are. And then thinking about the colonial export of maternity care and what we have done and continue to do to other countries, which is happening again today and now with the rise of the anti-normal birth campaigns. And that is having an impact in other countries. We get messages of going, what on earth is happening in England around normal birth, because now it's happening here, or it's galvanised campaigners who don't like the concept of physiological birth. So I think history is incredibly important, and we need to take heed, those of us who, you know, we've all have a shared responsibility. So flipping the angle ever so slightly, and I'm going to start with Gemma first. What, in your opinion, could be either the one thing, the biggest action, the biggest lever that we should pull to address, if not the whole maternity crisis, but maybe get us biggest bang for our buck? What would you suggest would be you would like to see addressed?
So I've interpreted this kind of question slightly differently, though.
Fine, that's okay.
So in my current project, I speak to women activists around the world who are challenging oppression. So that may be women working with Indigenous communities in Canada, or people who've had extrajudicial killings in Peru. So there's a range of human rights violations. And what I think we need to do as maternity activists is look at how other women have enacted social change through campaigns, because I've been in this space now for 16 years, and it's just like there's another review. And then I'm at the hairdressers and I can hear the women talking about their births, and it's equally as traumatic as mine was 17 years ago. And I'm thinking, well, nothing is actually changing. So how are other women doing this? So one of the groups that I spoke to recently, and their campaign has been quite successful, and there's a couple of things that they're doing differently to us. So I don't know whether anyone's heard of the spike ops. So in the 70s, 80s and 90s, the Met Police put undercover police officers in campaign groups. They were kind of campaigning on environmentalism and things like that. And these undercover police officers started sexual relationships with these women who thought these relationships were genuine. And these relationships went on 5-6 years. But their campaign has been pretty successful. So they have managed to push for a public inquiry, and their public inquiry has been ongoing now. It's the longest public inquiry in English history at 12 years. It's been investigated. So one of the things that they're doing, they've done all different things, documentaries, books, but one of the things that I've noticed is quite different. They are fewer women, but they are one campaign under one banner. And I find with maternity, you've got midwives doing that over there, doctors doing something over there, one charity's doing this, another charity's doing that. And we're not coming together to work as a huge monolith, because we are, as women, 50% of the population. So they also advise me that if you're doing any campaign, you need a multi-pronged approach. So for example, for maternity now, it feels like there's a lot of waiting on these reviews. Well, that's just one thing. And even when these reviews come out, they're only as good as the recommendations and the implementation of those recommendations. So we need to be doing many other things at the same time, but together. So that would be my...
I love the direction you took it.
That's quite different maybe than what you expected.
Karen.
Yeah, it's interesting. I mean, you've kind of landed on what I was going to say, and I think I alluded to the sort of first discussion, is that you've got a maternity system which now is divided into what we call LM&Ss. So sectors of London, for example, are divided into 3. But yeah, it almost feels like we're rivals.
Yes.
And there's, you'll have, a teaching hospital, UCLH will be there, and it'll be a rival to Queen Charlotte's, it'll be a rival to Royal Free, that we don't work together. And so for what I would do is I would change and just uproot that whole system. So where people need to learn from each other. So you'll have one hospital that will be doing really good work. For example, I'll bring in the perineal care. The perineal care, the way it's devised, absolutely hate it. I think everybody thinks about 3rd and 4th degree tears. 2nd degree tears are a great source of trauma and harm. If it was a man that had to give birth, and then his perineum was split open and the balls were hanging one side to the other, and they were told, oh, those stitches have come apart, and you went back to the hospital, no, that man would be having his balls stitched back together. But if it's a woman, they have to sit down and they just have to wait for a few months, and eventually you will see a doctor with all the trauma, the secondary trauma that happens with that. Now, different hospitals do that differently. So some will see women and they will resuture them quickly, get really good outcomes. Some people are waiting for 3 months. And it's like that with everything. Yeah. You'll see that in gestational diabetes. You'll see that in delivery of care. I was just saying that we don't use fetal pillows very much at our hospital. They're used for full dilatation sections. We use different types of instruments to support women to achieve a vaginal birth. But that is just a narrative that is it just occurs so much within the NHS, and particularly within maternity, where you've got really good learning, good outcomes in a particular area, when they're not shared with the hospital next door. And that has to stop. So I would change that.
So interesting, you tap into that sense of competitiveness, and I'm sure people who if you work outside London, the same thing around regions and near where I live as well, because sometimes you're competing for the clients in the area as well, because that brings money into the trust. So yeah, thank you for bringing that to light. Annabelle.
It's such a big question, but I think some of this speaks to what Gemma's touched upon. I'm glad Gemma brought up spike ops actually, because as I mentioned, a lot of my work focuses on reproductive coercion, and actually there's a documentary that I did with a musician who was experiencing reproductive coercion for the BBC that's recently gone at iPlayer. And just to say that their whole work has been really successful, but just to say one of the reasons that they can't get the impetus around kind of changing things around what reproductive coercion is, which is somebody forcing you to continue with pregnancy or forcing you to end a pregnancy, is because of things like spike ops, right? So if you actually did legislation to say that you were going to stop somebody coercing people to continue a pregnancy, then you'd run into issues where it's been, where the state has used it in case, and I think we've got the tip of the iceberg on that front. All of this is to say, I think what you mentioned, Gemma, speaks to a wider point. So I subscribe to something called reproductive justice, which lots of you may have heard of, is a term coined in the States, predominantly by black feminists who were working within the reproductive rights sector, and they felt that conversations around choice doesn't do adequate justice to some of their lived experience with reproduction, and they needed to broaden out the conversation to talk about the other nuances about how not just identities but structures impact our reproductive choices. So what it is the human right to have a child, not have a child, and have the resources to raise our children in the communities that we wish to. And that's the broad umbrella of what reproductive justice means. Now, in terms of levers to pull, what I notice is that across this sector, everything is very, very fragmented, right? So maternity sits outside, and it goes back to the point that I raised at the start. It sits out there on its own in this, you know, sometimes, yes, midwives are doing their own work, or obstetricians are doing their own work, and, you know, lawyers are doing their own work. But increasingly, I do see kind of a mobilization of these groups at reproductive, at maternity events and on boards and things like that. A little bit more. It's still not as people talking to each other as they should be. But what there definitely is maternity has its own kind of set of policies, health policies, outside of reproduction as a whole. And I think that actually weakens anything that people wish to address in this area. And I think if you look to the States, we see how this has functioned, right? And it's only recently been addressed. And one of the reasons it's been allowed to happen is because people like neat, tidy lines, right? So if we look at the example of termination of pregnancy, which is fraught because people have moral beliefs and things like that, but it's very difficult to disentangle from miscarriage, okay? Because births can turn into other things, and then you need to access medication, and if you introduce legislation around this, it's really difficult to medically determine which is which, and it harms everybody, right? Because of the onslaught of rights in the US, that's affected a whole host of areas. You've had people across the spectrum have to start talking to each other and mobilizing under a broad umbrella and alliance, because they've realized that it's all going to come crashing down, because the people on the attack don't actually care about any of them, right? They don't care about birth rates, like maternity mortality getting worse. They don't care about that at all. They're just onto their own thing. So I think we can learn in this country from what's going on elsewhere, that when you silo yourself, it automatically makes you weaker, and you can't address maternity care without addressing what's happening because of things we've touched upon. Somebody has a bad maternity experience, impacts their entire rest of their reproductive life course. Actually, what happened before in their reproductive life has a massive impact on their maternity experience. And so it's just not really making any sense. And that's the biggest lever, honestly, because we're stronger together. And when a whole movement comes together and says that this is a massive pressing issue for over half of the population, and these are how our issues interlink, and if you want to come and talk to me about menopause, you bloody better come and talk to me about the other stuff. They don't have a choice, because they can't come for a photo opportunity and not talk about all the other stuff as well, right? And sometimes when you try to push against that, people say, oh, but it's going to get too big, you know, and oh, how can we address this one thing if we keep talking about the other thing, and, you know, money gets mixed up. But the reality, and I'll just end on this, is that what happens when you silo things is ridiculous policy emerges. When I sit in my reproductive health clinic, people are treated like they live in a silo. So people sit in the chair, and although I have a skill set that is broad, I'm not allowed to do maybe 50% of my skill set in a specific clinic because I'm not paid to do that, right? So you might get somebody sit in a clinic that needs psychosexual counselling, but all that's paid for by the local authority. But the person's bringing a psychosexual problem. But this is menopause clinic. So now you're just supposed to, and this is what a lot of us experience. So the biggest lever for me is we need to make this coalition bigger. And I think it's going to be urgent because I honestly think that what follows or happens in the US transcends because of funding, policy, American scientific imperialism, which I could talk about all day long. I'll just throw that in there. But yeah, we need to, because the politics in this country is changing, and I think in the next 2 years we're going to have a massive onslaught on our reproductive rights, and we can't function in this siloed way because they'll come for some of it, and then we're going to be like, oh no, scrambling.
And that's it. If you restrict whatever your personal beliefs, which we don't need to share, about one end of the spectrum of family planning, abortion care, or what women do with their bodies at the time of birth, when you restrict one end, you restrict the other end. And we see that in the US court-ordered caesarean sections. You would have all seen the video of the woman on an iPad in labour with judges telling her that she had to have a caesarean section. I mean, the degradation, dehumanisation, the inhumanity of that. So I think you're very wise to be keeping an eye on the US.
Can I just give one small other point? Is just because I know some people are not versed in this, might not be as versed in this issue. So just give you another practical example, right? So a drug like misoprostol, for example, which we use to manage hemorrhage, for example, right, is also used in terms of abortion care, right? But it's on the essential drug list for like the WHO, mainly for postpartum hemorrhage because it's cheap and it's accessible in low resource settings. But when you start to get people to restrict it because they're against abortion, it then causes issues in the management of maternal mortality caused by hemorrhage, right? So this is what happens. You can't disentangle these issues because you end up hurting something else. And I think people need to be more cognizant of these things across our movements because I don't think people are well versed. Yeah.
Such a great example, really brings it to life. And everything that you were saying was a big part of the International Confederation of Midwives Congress last week. WHO, UNFPA, all the world leaders talking about not only some of the issues we're talking about here, but this joined up, it's sexual health and reproductive health. It's the cross the life course. It's not a midwives have a role. Our scope of practice covers all of that as well, but in the UK we certainly don't work unless we're in a siloed. We might come work in a sexual clinic or a termination service and we might then use our scope of practice there, but we're not doing it in this joined up way. And I think you highlight those perverse incentives for the fragmented care. Or this pot of money means I can't talk to you about that, or we don't have time. You just don't have time. It's not anything you want to do, but how the structure is. So I think that's incredibly important, and that's something, well, hopefully it's lead to the next question, which will involve you in some way. So just bear this in mind. So Karen, I'll start with you. What role, if any, do local communities have in contributing solutions to the maternity crisis? And for the purpose of this, you're our local community today, but I do mean that in our actual own local areas.
I think they are core. They're at the beginning of it, they're in the middle of it, they're in the end of it, they're in the continued cycle of it, and unfortunately it doesn't sit like that at the moment. I interestingly just this afternoon was leading a research conference, and somebody presented on PPIE, which has become a lovely buzzword. But I asked them, so when you developed your research protocol, which is essentially think of that like a guideline or a policy, did you include your patients and the public after you developed the protocol or before you developed the protocol? And invariably what we do a lot in maternity is we get the guideline and then maybe we'll ask a few people, to have a look at it and see what they think. But that means we get it completely wrong. And it has also led to certain gaps in care. And the one gap that I really want to highlight is that gap from 6 weeks up to 1 year. You know, when we see, particularly for my perinatal mental health work, that's when women are dying.
Yeah.
And the reason why women are dying is because they're lost in that system where traditionally it was plugged by social connections and community, and now we have a lot of third sector organisations that are trying to plug that gap, but it's completely, it's not, I don't even think it's funded for. The GPs don't own that part of the pathway, maternity doesn't own that part of the pathway. I remember I've got 3 children, and by the time I got to the third one, I could just about see a health visitor. It was shocking, the change within 7 years of not having somebody there to be able to talk about simple things about your child's development. So, and the problem is, because we have not included people when we decide what that pathway looks like, when they need to be very much at the beginning of it and core of how that pathway is developed. If that pathway was developed by you, I'm sure that it would look very different. Thinking about myself as a patient, if I was to develop that pathway, I would want a holistic assessment, which includes my psychological, my social needs. I want somebody to tell me how to exercise, how to squeeze my pelvic floor, send me to a Pilates class, a massage, you know, reflexology. I'd want to know about my return to work rights. I want to know about finances. But actually now we've just got this body that we deliver this baby from, and then off you go after 6 weeks. Oh, you're not bleeding anymore, are you? Okay, yeah, you can just about hold your wee, off you go. And I think it would be a very, very different system if we actually incorporated what actually our patients and public want at the core and centre of it.
Oh, I love that. Thank you so much. In case anyone's not sure, PPIE is patient, public, involvement and engagement. Had to remember all of it then. So it's the big thing in research, and I mean, England is paving the way in that, but like Karen says, it's no good just coming after you've decided that you want to do a particular project, and same for setting up your local services, and that's where we're seeing a mismatch between how it should be done and what is actually done. And not everywhere. Some places are doing it really, really well. So thank you for that. Annabelle, do you want me to repeat the question? No, that's fine. What role, if any, do local communities have in contributing solutions to this maternity care crisis?
Yeah, so I don't know, I don't know what I am. People call me different things. Organiser, activist, advocate, you know, and they all do mean different things. It's important to be aware of different labels. But at the heart of that, I believe communities have quite a significant amount of power. And one of the things is when you're trying to mobilise communities and you're trying to mobilise people, although a lot of people don't do this, and I wish people would do more, you study movements, right? You study movement building. A lot of people think movements and mobilisation happens by accident. It does sometimes, you know, there's a specific moment that occurs or something that happens that then makes people galvanise into action, right? We've seen that quite a lot more recently in like 2020. But actually, there is a lot of planning that takes place. And I think communities have a significant amount of power. If you look at successful movements, it's people-led, people decide what the priorities are, and through people pressure, you know, wider systems are forced to respond. And I think we can push things up the agenda through what I mentioned in terms of coalition building and speaking to people outside of your space. And I think we also have to be innovative. I don't think we're innovative enough. I've talked about, you know, speaking about the whole reproductive community coming together, but actually outside of that umbrella, our issues align to, you've alluded to this, to much bigger issues, right? You know, in my in the community that I serve as a consultant, and I deliberately went to this to a community that was more deprived and had certain issues because I wanted to feel like I could make a bigger impact there. You can't disentangle whether somebody has secure housing, you know, or somebody's migration status, whether someone, as mentioned, I'm an ambassador for Birth Companions. They do a lot of work around those that are incarcerated or probation, and those things from somebody's, you know, reproductive life and how they go on to experience maternity care. So we have to speak to people broader than just this maternity reproductive community. And I think, yeah, at the centre of this, communities have a lot of power. I think we need to be loud about what the problems we're experiencing are, and then the solutions will also be broader.
Thank you. That's really powerful. Gemma?
I suppose my thoughts are similar to Karen and Annabelle's. I'm going to be a little bit cheesy, but I think in our communities, we can be quite judgmental of each other as women. So when you are pregnant or giving birth, those decisions are so hard. Making the right decision for yourself and your baby, but you face a lot of judgment, especially online, and I see that a lot with the free birth community. Women are just vilified, but the people doing the vilification don't know women's situations. So you have your baby and you feel that kind of judgment about whether you had the epidural, or did you have the C-section, or did you only have a paracetamol, are you breastfeeding, are you bottle feeding? And I think just being a bit kinder to each other to bring us closer together. I think also we see a lot of vilification of midwives and doulas, and it's unhelpful. And I think if we're going to completely transform the maternity system for the better, we need to drop all that. We need to be in our communities together and doing less judgment.
Thank you. I think that's incredibly powerful to sit with and hold that, because we're much easier to control if we are divided, aren't we? So that's another way to look at it in a different way, even if, you know, we're all going to be a bit judgmental sometimes, but do we need to share it publicly online? Probably not. So we're going to have a little 1 minute quick round for each of you, because I'm just mindful of the big clock looking at me. So just to finish this session, and it's going to be over to you, audience, to ask your questions to our wonderful panellists. 1 minute each. Who is going to fix maternity care? Annabelle, just because I happen to be looking at you at that point.
The people? That's a really broad answer, but I think it does come through people power and people pushing for change. I'll just add, we've briefly touched upon it, but I think, like so many oppressive systems like patriarchy, I think there was this understanding with medicine that as medicine became, we had more female doctors and society became more kind of like liberalised. We have had improvements in maternity care that this issue would naturally fix itself. But I think that shows a poor understanding of oppressive systems and how people learn behaviours and just replicate those behaviours. So picking up on Gemma's point, some of the biggest kind of enforcers of patriarchy are other women, and even within medicine, you know, a lot of the obstetric violence people have experienced will be from women that have also delivered babies, right? So I think we need to address medical education, understandings of actual how these systems operate, and I'll just leave it there. But the people are going to have to push for change and use our collective voices.
Yeah, incredible. Thank you. Karen?
I'll come in to talk about something around improvement science, which is the 5 whys. If we interrogated every part of the system and then we said why, and somebody gave the answer and we said why again, and then we still carried on and looked a lot deeper into each structure, we'd be able to dismantle the decisions that we've made with no evidence or any proven evidence of benefit. So, for example, I'll quickly cite a hemorrhage project that I did with the NHS Race Observatory, but particularly at ourselves at Queen Charlotte's, where we realised that there was an equity gap in hemorrhage between black and brown women and white women. Everybody said it's hard. It's, you know, you'll see it. They continue to still talk about it within certain circles. Simply collaborating and asking why? Like, why does everybody get the same injection after they give birth? They've all got different risks. Why do we think it's only doctors that can decide who gets that PPH prevention? Midwives are more than able. Why do we do things differently in maternity? Again, maternity, we restrict medications for women, which are given to everybody else. When we know that there's a 500 ml blood loss and they're likely to get that, they all get TXA if you're in a non-maternity setting. So why don't we do that in maternity? Because we were scared about the baby, but actually, why are we scared? If you speak to the paediatricians, it's fine. So within 3 months, we corrected that gap. It disappeared. So I think that if we start to have that real scrutiny and that exploration of the system, the 5 whys will be brilliant. With a little caveat, it can't be the 5 whys on your own. It has to be the 5 whys with your lead midwife, your junior midwife, your cleaner who cleans up the blood afterwards, with your anaesthetist, with your cardiologist, with people completely out of the system, your haematologist, blood transfusion, with your patients and your people that work within the system. And that's exactly what we did. And we learned an amazing amount, and it meant that we were really collaborative in the way that we delivered that care.
Incredible. And I really love that it can't just be on your own.
Yeah.
It's a global point to move us forward as well. Gemma.
So who's going to fix them? So I think there's kind of 2 questions in this. So who is responsible? Ultimately, it is the government. And we've been waiting for decades and nothing's happened. So we have to force their hand. And so it goes back to Annabelle's point. It's the activists, and anyone can be an activist. You don't have to be a doctor or a lawyer. Just anyone can start doing something to help or to be part of this movement. So for me, it's activists and it's anyone. Anyone can make the change or be part of the change.
I love it. Thank you to you all. So, I can't believe how quick the time has gone. We have about 15 minutes thereabouts for questions from the audience, but I'm going to emphasise here as politely and respectfully as I possibly can. What we're looking for is a clear question to the panellists. For those who have more, and people have been to conferences, that's why they're sniggering, because they know this is a common problem. For those who have just more of a comment, something to feed back on, something to chip in on, I'm going to ask you respectfully just to hold that until we have drinks reception, and then that's the time and place for much more deeper conversations. We only have these 3 wonderful women for a very short time. So I think I've made myself clear without sounding too marmish there. So if anyone's got a question, we've got roving mics to come to you, and I've probably put too much pressure on it. Needs to be a question, so someone needs to come up with one now. But yes, just wave at us and we'll send a mic to you. Question down here. We've got a question down here. Thank you for going first. It's brave.
No, just thank you very much. It was a really, really interesting evening. I guess my question touches on what Annabelle and Gemma said. There's a lot of online noise and campaigning for a maternity commissioner. Do you think that post person has a role in fixing maternity care?
Oh, I'm going to give this to all of them because that's a great question. Annabelle, over to you, and then we'll come down the...
I'm actually really, because I haven't had a chat with Karen about this. I'm really interested to see what you think. So it's kind of touching upon, actually, we're having loads of conversations beforehand about our own experiences. I didn't have a great delivery and other things as well. And I think this kind of touches upon what I was talking to Karen, is that when an issue gets big, right, we have to make sure that there's a phrase, but essentially we're not making a career out of a problem, right? And we actually want to eradicate the problem, right? And it is an issue that a lot of campaigners and activists suffer from over time, right? And some activists, obviously, you can be paid or you lead a charity and it becomes your job, and that should support your livelihood materially and things. You still need to be making sure that being at the forefront of an issue doesn't become your reluctance to actually eradicate the issue, and it's something you have to constantly interrogate. All of this is to say is that I'm not saying that a maternity commissioner is that or would be that person. But I just think we need to ask honest questions about where the calls sometimes are coming from and for what purpose, and how that makes something different from what we already have. Okay, we have lots of ambassadors, lots of commissioners, and people kind of going around, and sometimes they even start off in a good place and then they're just talking at loads of conferences all the time, and I can't really see how this is making the issue change in any way. We're just talking even more than we were before. So I'm not entirely sure. I think the remits of the role would need to be extremely clear to me, because they will also cost money, and that's money that's not being spent on something else at a really critical time. And I guess that's, yeah, those are all my reflections.
I mean, I would say it almost needs to be depoliticised. That's the issue. The politics needs to be taken away. You've got, you know, we sit in so many of those spaces. I've been going to number 10, tired of number 10, I'm sorry, a bit tired of round tables as well, where I see a lot of people talking about the problem, as she's quite rightly alluded to. But what we need is an implementation plan. It's not that we don't have the information or we don't know how to implement it. So therefore we're not implementing it. It means that the leaders are not the right leaders because they don't have the knowledge. And we've got people sometimes in these spaces who won't step back or get the team around them that can implement that. It's not rocket science. And the other thing is that I will say is I also think we've got enough resources in maternity. I don't think we need more resources. We don't need more guidelines. I love the women's health strategy, but I don't think we need another strategy. We just need to get on and implement things in the right way. And we've shown that we can implement things, you know, like the Saving Babies Life Bundle. Unfortunately, that caused more harm to black and brown babies because it wasn't implemented in the right way. But I really don't think it's going to be solved by a maternity commissioner. It's about making sure we've got the right people in. So if we were thinking about the NHS as a company, I'm fortunate to have done an MBA. I love things around all things around business. I'm telling you, if you had, who was it? Some of those good, what do we call them, the apprentice guy. Yeah. If he was there sorting out the NHS, it would be sorted. Because there is so much waste in maternity, we all know it. You know, even right down from gloves being thrown into the bin, gauze swabs that get thrown once you deliver. There's so much waste within maternity. We have the resources, but we don't have the people who have the foresight, who know how to implement it, who are right at the top levels. That's my personal opinion.
Gemma, what do you think about Commissioner?
It just feels a bit like lip service to me. I just feel like I'm being patted on the head and go, here we go, all your problems are solved, we've got this person here. And for me, it's not that maybe this person could galvanise something theoretically, but I think when you've been in this space so long, you just think, really, what's this person going to do? You know, we're talking about systemic problems. We're talking about problems that are also coming in from the way I view things. We've got a major problem in our society with misogyny, and underneath that we've got racism, classism, elitism, homophobia. This is in wider society. And then we see these things manifest in our institutions, in our criminal justice system, in our education system, in our housing system. So of course it's going to appear in our maternity system. This commissioner cannot solve all that. Only we can do that as a society. This commissioner will just turn up, as Annabelle said, at conferences and do a lot of talking and get paid for it. And then more women will go through the system and come out traumatised. So for me, maybe something could happen, but the problem is way beyond one commissioner.
And I think, you know, I said the other day, sorry, if it okay.
No, please.
Like, I think sometimes it's almost that we've got to wake up. We've almost got to wake up as a group of women in a society to recognise that, first of all, we're not just a womb and ovary. So this whole femtech, women's health stuff annoys me to a certain extent. We've got a brain, we've got a heart, we've got bones. There are other parts of us that need sort of health to be sorted, essentially. Yeah. But we are really living in a country with a boys' club. And I think most people haven't woken up to that fact, where the people that are governing us and creating policies and protocols for how our maternity in every part of society is structured It's essentially an old boys club of people who are in echo chambers, who go to the same sort of universities to deliver the same sort of policies, who are still not impacting, who are giving, you know, a sense, you know, we know through the COVID crisis, they're giving contracts to their buddies. I still can't believe in the NHS that you cannot hire a handyman to come and paint your wall. You have to get like 3 different quotes, and then it costs about £3,000 to paint a room on the labour ward. Why? I mean, we could get somebody to do it for £500 on handyman.com, and it's the same. And then our women would have a better birth experience because the paint wouldn't be peeling off the wall. That's just another example of how it, you know, it's causing harm to our maternity services. So,
and who do and the convoluted bureaucracy to go with the medicalisation and institutionalisation. You've got the bureaucratisation of medicine, and maternity sits within medicine, and then who does that suit and what power structures and what power does that retain and hold? Because like, you know, there's some quite interesting stuff going around social media, how it costs, I don't know, it's 50, 60 pounds to change a light bulb. You know, your box standard £2 light bulb, but because of this procurement issue, and yet certain people could get fast tracks. So it's hard not to be cynical when it comes to those, but by unpeeling the layers and understanding and knowing that is an issue, I think is a start. That awareness, I think, definitely helps. Who's got a question? Any? Oh, we've got 2. Kate here, and then you over there in the white.
Thank you. Thanks. Thank you, all of you. Karen, I just wanted to ask you a question. I love your emphasis on implementation and wanted to ask you where else you've used the 5 whys.
I use in everything. I think it's really interesting. I think when I look at myself, I would say I'm a woman who's lived many lives. I did a biochemistry degree before I did medicine. I've worked as a GP receptionist, as a cleaner, as a healthcare assistant. I've done, you know, worked in a swimming baths as a waitress. I've just done lots of things within the ecosystem of healthcare. And I think it means it gives me a very diverse view of thought, and also that I just don't sit and just go with the status quo. So I've worked in, you know, done many projects. And I've also brought the baby project into London, into the UK. That was us at Imperial. I started that. And that now runs within Scotland. Scotland took it on board when we spoke to the minister. The UK, as I said, I've been to number 10 before. We're about to go ahead with it, and then the Prime Minister changed, so we lost that. But spoken to other people abroad to help them, and that is a process of looking at the 5 whys, again, implemented with our part of the Perineal Health Project to say, why don't we resuture women? That's, again, the concept that we use. And it was just that somebody decided, I'm sorry to the men in the audience, some man decided somewhere a long time ago that actually maybe it's infected, so therefore, oh, it's infected. But actually, you know, the white stuff that you see, it's not infection, it's granulation tissues, it's the body healing. So that assumption, so then once you start swabbing, you realise actually it's not infection, it's healing. You don't need to slough it all off. You actually need to bring it all together. So that's another example of where we use, so those are 2 for you. But 5 whys, really good.
5 whys, really,
really good.
practical. So
very practical,
yeah. Question.
Hi, so I'm a filmmaker and I'm interested in how growing up we learn about what birth looks like. And I was wondering how the 4 of you learned what birth is like and what it looks like growing up.
Oh, great question. I feel like putting pressure on the audience is going to be my thing now. I'm loving these. Annabelle.
Yeah, it's actually interesting. So I don't have any younger siblings. I'm trying to think about my first encounters. I think, so I have some younger cousins, and I think kind of my first encounters were kind of postpartum, and ideas about healing and things like that was from my auntie and her recovery with them, and also seeing her breastfeed. So I think from my memory, that would be my first formative memories. But can I be honest that a lot, and I've spoken to some of my other, you know, medical school friends and things, our understanding of reproductive health is absolutely terrible. I know because I deliver sex education in clinic in this really poor time setting, constantly just explaining to people basic anatomy and what happened to them during their delivery. And, you know, I can't even get to the problem sometimes because I'm doing basic sex ed. And similarly for myself, I learned a lot from going to medical school. So I always have a lot of empathy for people, because if you didn't go to medical school, I wonder, because a lot of my first encounters came through my medical school experience. So just to say, one of the reasons I actually realized that my period was abnormal is because I went to medical school. Like, I had a hemoglobin of 8, I had very heavy period. I also discovered I had sickle cell trait at the same time. And none of this had been known to me until I was 18, and I went to medical school and I, you know, got a lecture and looked in a textbook. So yeah, that's what happened to me. And unfortunately, I think it's quite similar for a lot of my peers. So a lot of sympathy and empathy for those that don't get to go through that system, because there are a lot of gaps that never get plugged.
Gemma, what about you?
So I didn't really know anything about birth growing up. I had 2 stories in my head. My dad always said that his brother was born at home, and that was obviously clicked about home birth. But the midwife arrived on a bike with a basket at the front, and one of his sisters asked, "What's in that basket?" And the midwife said, "The baby." So that was kind of a story that I grew up with, that it was almost like historical. People gave birth at home. It wasn't seen really as, I didn't have it in my mind that it was a kind of a contemporary thing. But one of the other stories is my mum always said about how traumatic her birth was. And I think it really impacted her life long term. She planted that seed in my head. But when I went to give birth, I was thinking, well, now it's whatever, 27 years later, I'm going to be fine, because that was the past. It's not like that now. So I don't know whether her story almost made me less prepared, because I thought the world has surely moved on from there, but it hadn't.
Karen? Very interesting. So you want to know in particular what is good birth, or our first experiences of birth?
Just how you learnt about
How I
existing.
learnt about birth, so it's really interesting.
Films,
Yeah, it's a
family.
good question. You're good. So I would say I've probably learnt a little bit about birth because I had a younger sister. I'm a twin, and my mum always talked about her birth, how she almost died because she had a postpartum hemorrhage after us. But then 8 years later, she had an unexpected arrival of my younger sister, and I just always remember her in a blue dress with a bow, coming home, just very happy and having a baby sister. But I think your question is really good and speaks to the whole of maternity, because I then remember as a medical student, I always loved obs and gynae. I always wanted to do it from, I don't know, probably when I was about 8, I don't know why. But I just thought the miracle of birth was just fascinating, and it was just one of those things that really was about us being humans that connect and reproduce. And Chelsea Westminster was my house job where I saw my first birth. And it was this woman who was just so beautiful in her birthing experience. She had no epidural. She delivered this baby, the perineum stretched. I thought, oh my gosh, is it really going to stretch? And it stretched, and this head popped out. Baby was born, she didn't have a tear, and it was just this perfect experience. I'm like, yes, I'm going to be an obstetrician that does lots of normal deliveries. And I do actually still now. I do a lot, all the way from water birth, all the way up to caesarean section. That's one of my great passions. I then went to theatre and saw caesarean, and I saw 2 doctors siding on either side, my first caesarean, and they said, okay, ready, steady, go, and they both pulled, and I thought, oh my gosh, that is awful. Actually, it wasn't really awful, it's just pulling the muscles apart, no tearing, but that stuck in my mind as a real, it was almost a bit traumatic for me. So I very much then said to myself that I always want to try and do vaginal deliveries, and it impacted how I birthed. So my first birth was attempted vaginal breech delivery, because I thought I never want to have a caesarean. And I think it goes into some of the conversation we were talking about women who free birth, where nobody really truly asked me, why your waters have gone, you're labouring for 2 days, why are you not having a caesarean section? And that's partly because of that initial experience that was traumatic when I saw that caesarean section. It then calls in for us to understand that as caregivers, we can sometimes influence or make decisions for other people depending on our own trauma. But we don't often reflect on that. As midwives or doctors, we're not taught to hold that and to learn to be impartial. And through that experience, I then had two VBACs after I had my breech cesarean section. I've learned to very much hold women in a space where you are allowing them to make that decision. And you allow them to make that decision by bringing calm. And a lot of people don't understand that the connection that we have when we are there with somebody as a caregiver, you can see the brain waves literally change. You are either activating their sympathetic nervous system or activating their parasympathetic. Obviously, with your within a parasympathetic mode, you're better able to make decisions that are safe for you and your baby. If you're not, you're like, oh, risk. You're going to really affect the way that woman holds that decision and then sometimes runs away from healthcare to go and free birth. And so the one question I always ask when women come and they're out of birth guidance is that, why is she out of birth guidance? What trauma does she hold? Who has had a discussion with her that may have triggered the trauma even in that pregnancy, or what messages are coming from outside of the immediate maternity system that are affecting her decision? And I think sometimes we're just too black and white as doctors. We're just like, oh yeah, you know, you want a water birth with a breech, tick, 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 you're mad, off you go there. and it causes harm. I've seen it cause harm. And, you know, I always remember a story of a woman who essentially was 45, got pregnant naturally, decided she wanted a home birth and had beautiful counselling, out-of-birth counselling. Everybody was holding her in her decision. But the one thing that it failed to speak to her about is that she was actually scared of hospitals. That's why she chose a home birth. So the point at which she developed meconium, she refused to come in. And the baby passed away by the time she got in. But had there been a clear plan to understand her psychology and give real individualised care, which is what we're lacking in maternity, which requires time, it requires a carer who's not fatigued by the system, then we will also get better outcomes. Yeah.
And just to say, that was beautifully put. I think this just ties into what I was saying earlier, is that it is just too late to have those conversations in maternity care. So I do a lot of complex contraception, and we're supposed to in the community, only, as I said, 50% of pregnancies are planned, and it's probably even less than that because that's a broad umbrella of what planned is. When I remove somebody's contraception, and it's lovely when they say, oh no, I'm wishing to conceive, and we do preconception counselling, it's brief, it's rushed, and it always focuses on things like you taking your folic acid, right? You know, I try to have a broader conversation about, you know, what miscarriage looks like, what subfertility looks like, and navigating those systems, you know, and all of these different conversations. And when we're talking about areas that really need to be expanded upon, and we build the vision of the world, the people build the vision of what they need, right? People need this. People are always, there's a complete absence of preconception. Like, why can you not go and speak to somebody about all of these things in advance of your choices and decisions? Like, where is that person? And it doesn't need to be a medic. This could be a whole new person, right? But where's that person? Where have they gone? And they've not really ever truly existed. Even when we had family planning clinics, it was all very much geared towards, you know, this specific thing. You should just be able to openly go and have a conversation about this breadth of conversation, and that information resides somewhere. So when you do decide or whatever, that can be passed on to the next person, and we get those kind of seamless processes. So yeah, it's much too late, and you're yeah.
You only have to see about the state of social media to realise sex education's gone very wrong here and the US for men, boys and girls, men and women. It really reflects that point. And then at some point, how can you ask those questions? How can you be in that safe place in order to do that? And did you know that there's 3 holes, not 2? And where does the tampon go? And things like that. I'd just also like to remind us, you know, I'm a researcher, as most of you know. I bang on about it all the time. We do have the evidence. We really have the evidence. We have strong, robust, it's the strongest evidence we've ever had for what works and how it works to deliver person-centered, individualized, safe care that optimizes outcomes. We know from the international incredibly robust evidence that where midwives are resourced, and enabled to practice midwifery, not obstetric nursing, when they are built into the maternity infrastructure with good, positive collegiate relationships with skilled obstetricians, as we have seen here, and other medics, and when all of those professionals are practiced with cultural humility and respect, we know this transforms lives. We know it. We see it, and some of us have been lucky to be part of those journeys, or we've experienced them for ourselves. And for those who haven't been lucky to either experience it for themselves during their own journeys, then that missing, that trauma, that gap, the negativity, you know how important it is just as much as someone who's had a positive birth, because it wouldn't hurt if it wasn't important. And it is important. So we know that relational care, whoever that comes from, if it is some other new worker to give that sexual education in the community, if that's relational, doesn't matter who it is, relational care transforms lives. And we also know relational and positive care experiences, regardless of the medical complexities of an individual, or the unexpected events, or the mode of birth. We get so fixated. And yes, my passion is physiology. Yes, I'm part of that problem, I suppose. But it isn't about mode of birth. It's about the woman or birthing person's experience and how she got there to that mode of birth. We know that's the transformative bit. It's not necessarily the emergency cesarean or the instrumental birth. It's the preceding 5, 10, 20 minutes, half an hour before that makes the difference of maybe disappointing. Oh man, that is not what I wanted. But I know it was needed, and I felt safe and I felt cared for. I trusted my clinicians. They had my back, they held me. That is what transforms lives. And not only for the individual in our care, but their partners. We know more attention is being paid to birthing partners, their emotional needs, their mental health, and the long-term implications and ramifications for the family when they experience trauma in the birth room or in the immediate postnatal period. So we know our care is transformative for that individual, the partner, the babies, and for that transition to parenting. So we know what works. We just need the political, just is doing heavy lifting, guys. We just need the political will to make that happen, and hopefully prime ministers who last longer than a year or two at a time. So just as I finally wrap up, I want to introduce you to another special person who's here tonight. I want to give a warm welcome to, and thank you to Elizabeth Ube, who has come all the way from Sweden to be here with us tonight. And her work is being showed in the Atrium, one of her exhibitions. So given it, the reason why I had to have Elizabeth here was the nature of the discussions, the complexities. Well, I knew we were going to go politics, social culture, and it's also difficult. It's such a challenging environment. But Elizabeth offers her work offers us an antidote and allows us to feel what we know to be true and how maternity care can be fixed wherever we sit within that. So Elizabeth is a midwife, photojournalist, writer and artist, and she has captured this antidote to the problems in the Power of Love exhibition. So I want to thank Elizabeth for being here, and we're all going to go look at it in a minute. So just as a reminder, and I will shut up in just a sec, we have got Threads of Protest exhibition here. If you guys haven't seen it, it's on till 1st of August, I think. 31st of July. I'm getting nods from the back. Yeah, 31st of July. Please go and see it. But obviously, if you don't do it tonight, it will still be around for a little while longer. Elizabeth's work is being showcased in the Atrium, where we'll have drinks in just a moment, and they're up on the projector. And there's some leaflets I think our team have printed off so you can understand a bit more about Elizabeth's work. This isn't her only exhibition, does loads and loads of other stuff, so please go along to her website so you can see all the different interesting intersections of Elizabeth's work. And I said I'd come back to Embarrassing Annabelle again. She has got her books with her, so if you want to find her out there in the Atrium, then you'll be able to purchase one as well. Okay, thank you so much to our panelists.